Hello everyone, my name is Megan McGrath and I'm a fourth year pharmacy student at the University of Connecticut School of Pharmacy, and I worked in conjunction with Dr. Jennifer Gerardo, a clinical professor, on this project, and today I'm going to walk you through a summary of a blog post I wrote on an important topic in pediatric infectious diseases, which is streptococcal pharyngitis. The blog post I'll be discussing is titled Optimizing Care in Streptococcal Pharyngitis Using Clinical Prediction Tools to Aid Antimicrobial Stewardship, which I wrote for the Pediatric Infectious Diseases and Immunization Update series, and you can find it on the UConn School of Pharmacy website. Streptococcal pharyngitis is a common disease state that is seen in children primarily in the primary care outpatient setting. It is caused by group A streptococcal species, notably Streptococcal pyogenes. The risk of children developing streptococcal pharyngitis is 93.2 cases per 1,000 persons among children 3 to 9. And then risk considerably decreases as age increases, with 40.9 cases per 1,000 persons among those 10 to 18 years old. A big concern in streptococcal pharyngitis is children have a higher incidence of asymptomatic group A strep colonization. Naturally, it is estimated that up to 20% of children may be colonized with group A strep, versus an estimated 5% of adults carry group A strep. This plays an important role in testing and subsequent antibiotic treatment revolving streptococcal pharyngitis infections. Overtesting is a primary concern in streptococcal pharyngitis diagnosis. Overtesting can lead to many false positives in children due to them being previously colonized with group A strep but not actively experiencing a strep infection. This is why clinical prediction tools have been introduced to help reduce overtesting and reduce inappropriate antibiotic treatment. The three tools that are used to create a clinical prediction score are the Centaur, McIsaac, and Fever Pain tools. These incorporate different factors of clinical presentation to stratify the probability of a patient having a strep infection. Low-risk patients with low probability of group A strep pharyngitis infection are not tested and are told to follow up in a couple days if their acute pharyngitis does not resolve or gets worse. Moderate and high-risk patients with a high probability of having a strep infection should receive rapid antigen testing and appropriate treatment with antibiotics if they are positive. The three clinical prediction tools are used to evaluate a clinical presentation of a patient regarding their symptoms such as fever or absence of cough, or different physical exam findings like tonsil swelling or cervical lymph node swelling, to compile into a score that determines the probability of a strep infection versus other causes of acute pharyngitis. Scores of 0 to 1 are considered low probability of strep infection and do not require rapid antigen testing or antibiotic treatment and should be told to follow up if their condition worsens. The McIsaac tool was adapted from the Centaur tool to be used specifically in pediatric patients, and it adds an extra point for children 3 to 14 years old due to the increased likelihood of strep infection in this population. The Centaur and the McIsaac tools have been well validated, but the Fever Pain has not. We can assume that the data will be somewhat similar, but there has not been any official data published. The Fever Pain tool can be used to quickly assess symptoms, so it might be easier to implement in a busy ambulatory setting. The guideline recommended treatment for streptococcal pharyngitis infection is with an antibiotic. The first-line treatment options are penicillin or amoxicillin. Amoxicillin is more commonly used due to the tolerable taste in their wide array of dosage forms. The dosing is 50 milligrams per kilogram per day with a max of 1,000 milligrams per day, and this can be divided into 1 or 2 daily doses. The duration is for 10 days, as this has been the only duration that has been shown to reduce the risk of acute rheumatic fever. This disease state is one of the only disease states where it is still important to counsel patients to take the entire course of their antibiotics, regardless if they feel better or not, as it is important to prevent complications. Some of the alternative options include intramuscular penicillin as a one-time dose, which can be a convenient option for patients who have significant vomiting, poor oral intake, or adherence issues to that 10-day duration. Cephalexin is the preferred alternative for patients that are penicillin allergic, but it does share a side chain with amoxicillin, which poses a very low cross-sensitivity risk, so it should be considered in patients that have a non-severe amoxicillin allergy. Clindamycin is another alternative that can be used for patients who have a penicillin and cephalosporin allergy or contraindications to other first-line options. This topic is important for pharmacists to know about because currently pharmacists in 8 different states across the U.S. have the ability to test and treat for group A strep pharyngitis independently of a provider, and many more states have that ability under a collaborative practice agreement. Pharmacists should be able to utilize these clinical scoring tools in their practice if they are frequently assessing these types of patients in an ambulatory setting. These tools can help them reduce overtesting while still identifying the proper patients that need antibiotic intervention to avoid complications. Thank you so much for watching, and the full blog post is posted on the UConn School of Pharmacy website if you want to learn more. And this is our disclaimer for your reference.